all those of you, there's a Google Doc which is attached here in the chat. Kindly log into it. So the thing is going to be, we are gonna have 20 spotters, 45 seconds each. First, we'll run through the spotters. You submit your answers on the Google Doc. And then we'll discuss after all 20 are done. And by tomorrow, we'll see who the top three are, and they'll be getting extra 3 months extension. Everybody was promised 3 months extension, whoever joined in with the pre-booking, so that's there, and you'll get 3 months in addition, right, if that's a question. So quite exciting. This is the first quiz that we are having, and if you guys enjoy, we'll have more of these. The Google Doc is just there in the chat, posting the link again, right? So you can just access this. Your name and your phone number and your email ID would be mandatory to be entered, and then you answer uh, the answers one by one. Every question is 5 points, so a total of 100 points is what we will have. Okay, so that's the idea. I hope everybody got the Google Doc where you got to submit the answer. Just participate. Even if you are a first year, just see what you think is the answer. There's a mixed bag. Some are easy, some are difficult. So that's how it's going to be. We'll start in 4 minutes. In the meanwhile, just sign in. I think it'll require you to sign in. Okay, any other doubts you can ask me now. We have 4 more minutes before we start with the questions. Everybody could access. You have to log in through the laptop. Anything is fine. Through your phone also is okay. You have to sign into your email ID. Anything is fine. I think having two devices handy would be better. If you log in through your laptop with the Google Doc and you have the app on your phone, then I think it'll be more comfortable for you rather than having just one device. Yeah, so log in through the laptop in the Google Doc and use your phone for seeing the spotters. I think that is what you can do. Yeah, Google Doc you can access on any device. Just copy the link. It's also there on the Telegram. One of you is asking Telegram channel. It's Conceptual Radiology is the name. Yeah, just search. You'll find it. It's a public channel only. So I have put the document there also. Okay, everybody could join. Right, so those of you joining in now, there's a Google Doc which is there, which I'm attaching in the chat. Log into it, mark your answers there. Every question, 45 seconds. I'll repeat this again when we start. Let me just share my screen in the meanwhile. Every spotter, 45 seconds you'll get, okay? How many of you have like spotter quizzes in your department? Anybody who has? We used to have them at AIMS. I don't know about other colleges. So want to know how many of you have these quizzes, JR quizzes in your colleges? Weekly ones. That's good. Weekly ones is very good actually. Very high frequency that is. Which college is that, Alicia? Which college is that where you are having weekly? Ah, nice. All right. So I think we will start. So now for once and for all, to bring you all on the same page, I am sharing the Google Doc here in the chat. You have to submit your answers here, sign in through your Google account, use this in another device so that you can access both at the same time. Right, if you don't want to submit, that's also okay. You can just attend, but you have 3 months extension, which you will get if you are in the top three. So I think you should all participate just for the sake of it, if not for the prize. At least no voice. Is my voice okay? Is my voice audible to all of you? I think you'll have to, yeah, join audio. Okay. Right. So 45 seconds, every spotter will run through the spotters. Everybody has understood. Yeah, no doubts. So 45 seconds for every spotter you will get, and you mark your answers. I mark your answers as in write your answers. Don't use any short forms. Use the full forms because that is how it will be marked. Please disable the annotation on the app. Admin, if you can just disable the annotations on the settings, that will be good. All right, all set, all ready? Just give a thumbs up on your things. Where to answer? That's what I've been saying since the last 5 minutes. So this is the Google Doc where you have to answer. Okay, this is the Google Doc where you are going to answer. Posting it again for the final time. This is where you have to mark your answers. This is where it will be scored. Okay, don't answer in the chat. Please don't answer in the chat. Okay, all right, all set. Starting now with the first one. All right, starting now with the first one, and time starts now. Please disable the annotations. Write the full form. Wherever there are short forms, that will not be accepted. So write the full forms of the diagnosis, just the diagnosis. Description will not count, only diagnosis. Okay, all of these are spotters with one word or one phrase diagnosis. So I only want diagnosis, name, and full form, not short forms. Caps, non-caps will not count. That's okay. Anything is fine. Don't write in the chat. All right. Time's up. Moving on to the next one. Spotter number 2. I just gave you some extra time for the first one because we were getting used to it. Whoever has joined now, there is a Google Doc which I am pinning in the chat. You will have to answer in that. Log in, enter your details, and start answering now. This is the second one. Okay, you're gonna get 45 seconds for each. Time's up. Going on to the third one. Mention the side of the abnormality and the pathology. In this case, you'll have to mention side and abnormality. If you don't think there is one side, then write bilateral. If you think it's both, if you think none of the sides are abnormal, write normal. If you think it's one side, write that side name, right or left. Don't use short forms, use the complete name of the pathology. Okay, moving on to the fourth one. Don't describe, just the diagnosis. No marks for description, only diagnosis. Whoever joining now, Google Doc, there, that is where you have to answer. This is the fourth one. Yes, it's written on top. Time's up for this one. Moving on to the next one. Fifth. I'll give you a hint here. It's an ultrasound of the eye. Ultrasound of the eye. Don't annotate, please. You have to answer it. Oh my God. You have to answer it in the Google Doc. Don't just annotate on the screen. Can you please check the settings and disable this? Moving on to the next one. This is number 6. All right, time's up for this one. Moving on to number 7. Only the diagnosis. Here you can name the diagnosis or the syndrome. Both will get correct answers. Just the diagnosis of the pathology or the lesion or the syndrome, if you can name, both of that will yield you correct answers here. For everyone, this is the Google Doc where you're supposed to answer. For those of you who joined late, this is number 7. Number 8. This is DSA of the kidney is my hint to you. DSA of the renal artery has been shown to you. just the diagnosis of the condition, not the description. Number 9, name of syndrome only. Time's up. Number 10, the CTPA image. I can give you one hint. Patient complained of hemopsis. I just want the diagnosis. What is the name of this pathology? Next, number 11. No hint here. Okay, I can give you one hint. Patient is complaining of chronic foot pain and discharging sinuses from the foot. Very big hint. Number 12. The dates have been mentioned. What's written below are the dates. So what happened on 26th August and what happened on 29th August has been mentioned. I think pretty evident, this one. Just the name of the diagnosis. Don't describe both of the x-rays. Time's up. Number 13. What is this called? For those of you who have joined late and are wondering where to submit the answers, I am sharing a Google Doc in the chat. You can answer from this question onwards if you want. We will finish 7 more and then we'll discuss the answers. Next, mention the, no need to mention the site. No, it's not MCQ type. You just have to, don't need to mention the site, just answer what the diagnosis is. Here, site is not needed. Why not MCQ type? Because the exam that you will give, the spotters will not be MCQ. You won't be given options. You'll only be given image and you'll have to write the answer. So we have to practice for that. All DNB, MD, every exam, you will have spotters wherein just the image and the answer. Number 15. Here, this disease is known by two names. One is the generic name, one is the big name. You can write either of them, you'll get answer for both. One hint also I've given in the process. Both of, when you say physics and pediatrics class, they are like huge subjects in themselves, right? So we will continue to have different topics in order of importance. Yeah. Next, number 16. This I think everybody should get. The first time starting off with ultrasound physics, gonna upload recorded lectures as video of the day for ultrasound physics, and then we'll go to MRI after that. I will also not take the topics which other faculty have taken, that makes no sense. But maybe we can have a case discussion or something of that sort on liver tumors. Next. So here, this is an MRI contrast agent. I hope you have seen that video. So this is to see if you are watching the videos of the day or not. So you will tell me what is the nature. Is it ionic or non-ionic, linear or macrocyclic? So both you have to write ionic, linear, non-ionic, macrocyclic, like that. Okay. And it's also very important for table viva. You frequently have contrast media which are kept in table viva. So we all need to know that. Time is up, but I'm going to give you 5 more seconds for this one because you have to write more. So I'm going to give you 10 more seconds just to finish backlogs. All right, going on to the next one. Patient who has new onset hypertension and CCT has been provided to you. What is this condition called? That's what I want to know. It's a 4-letter word, if I can give you a hint. 10 more seconds for this one. The DNB papers will be uploaded from tomorrow only. In fact, like we'll keep uploading them topic wise rather than paper wise, topic wise, so that it's easier to access. Okay. Going on to the next one. This, what you have to do here is just tell the diagnosis of the condition. Last one now. 5 more seconds for this one. Last one. This is to test if you've been seeing the spotter of the day, radonat of the day or not. So this one you will know very easily if you've been seeing spotter of the day. Just the short form will also do, the full name will also do here. If you, because it's a big name, if you just write the short form, we'll accept that also. So just gonna give you 30 seconds extra after the time is up. So 5 seconds more. Okay, so time is up now. I'm just gonna give you 30 more seconds to wrap up whatever was missing, partly written, and then submit. All right, so you have 30 more seconds to go. And then we'll start discussing. Right. So I hope you guys have submitted all of the papers now. We won't be taking any more entries done after this point. Okay, how was it? How did you like giving this quiz? So we used to have such a quiz, once in every semester, which was a JR quiz, and it used to be a lot of fun. Yeah, so hopefully we can do this. I was thinking we'll do it every month. That would be nice for all of us, to have that competition, and slowly we'll get used to the format and all also. This was the first time that we did it, so maybe you're not used to it, but slowly you will get used to it also. डिप्रेशन की कोई बात नहीं है. I mean, it's okay. So here you have a mixed bag, right? You have a mixed bag of people who are there, so that's okay. But there will be final years who will benefit most out of it, and they will be the ones who are the winners maybe. Please don't annotate. अपना screen में annotation का button off कर दो. I don't know why the admins are not able to do this, but please एक बार वो off कर दो. Don't annotate. Was it tough or moderate or easy? I think it was a mix of all. These are the kind of questions that you get, in the exam. So थोड़ा तो difficult था, but these are the level. This is the level that you get in the exam, and most conferences that you go to, you will see all of these cases. यही सारे spotters आपको मिलेंगे. So these were the usual. So I'm starting with the most cliched ones. Okay, obviously for first year it will be tough, right? So वो तो है ही. ठीक है, बट स्लोली स्लोली यू विल लर्न, है ना. सो जैसे जैसे बड़े होते जाओगे ऐसे सीखते जाओगे, एंड इट्स ओके. इट्स अ लर्निंग एक्सपीरियंस. अगर टफ लग रहा है, इट्स अ लर्निंग एक्सपीरियंस. सो नाउ जस्ट डू मेक श्योर यू डोंट गेट दीज रॉन्ग. दैट्स व्हाट यू हैव टू डू. ओके. ऑलराइट, सो लेट्स स्टार्ट ऑफ. चलो डिस्कस करते हैं. व्हाट डू यू थिंक इज द आंसर टू द फर्स्ट वन? Very good. It is proximal focal femoral deficiency. So this is a condition wherein the proximal femur does not develop. It's a developmental anomaly where the proximal femoral epiphysis does not develop. And what you see here is a limb discrepancy, and look at it. So this is where you only see the distal femur, which is articulating with the acetabulum. So this is what is proximal focal femoral deficiency. So here, if you have written the full answer, you will get the marks. Proximal focal femoral or proximal femoral focal deficiency, either of them you write, you will get the marks for this. Okay, so this is the first one. Second one was easy, I think. Iska, anybody can tell me what you think is the answer? There's a T1 weighted image. What do you see here? Look at the hotspot. The pituitary hotspot should have been here in the sella, but it is where? It is up. So what do you call this? This is what is called as the ectopic hotspot. And what does it indicate? When the posterior pituitary hotspot is not there in the sella, it indicates that there is stalk transaction, right? So this indicates a pituitary stalk transaction, that the posterior pituitary neurotransmitters, basically ADH and oxytocin, which are the neurosecretory granules that give this T1 hyperintensity, because they are stored. Posterior pituitary does not produce them, they are stored. So that's why there is a posterior pituitary hotspot. When this is not there, that means that there is the stalk which was going to transmit these from the hypothalamus to the posterior pituitary. That is what is abnormal. Okay. No abnormality with the skull. I don't think there is any abnormality, just an oblique section, I believe. Okay, so this is what you had to focus on, posterior pituitary hotspot. Very commonly asked spotter, this one. What do you think is this? This, I think, first year should also be able to answer. ये NEET PG level का question है. What is this? Seeing on both of the proximal femur, there are these, yeah, there is this necrosis which is happening, right? So when you see this in the superior aspect, superomedial aspect, this is AVN and this is bilateral AVN. So the answer which would be accepted is bilateral AVN or bilateral avascular necrosis. I had mentioned that right the side, okay? So this is bilateral avascular necrosis. What is this one? Very typical one. What you see is a marked signal intensity drop in the liver. What you also see is some part of the pancreas seems to be involved, right? So whenever you have liver and pancreas, this is primary hemochromatosis. Now, if I would have been a strict quiz master, I wouldn't have accepted just hemochromatosis. It would have been primary hemochromatosis. But I'm a sweet person. So even if you've written hemochromatosis, that will do. Why? Why the importance of primary versus secondary? So if it is secondary hemochromatosis, which is because of transfusion, then you will see the spleen involvement. If it is secondary hemochromatosis, or basically what we call as hemosiderosis, which is because of chronic transfusion like thalassemia, I will see the involvement of liver, spleen, and bone marrow. In primary hemochromatosis, what we see is the liver, spleen may be involved, may or may not be involved, pancreas is involved, pituitary is involved. So I see all of these organs. So whenever pancreas, pituitary, heart, all of these show the drop in signal intensity, that is your primary. So this is what you need to remember, primary versus secondary. Yeah, bone marrow as well. So vertebrae also, you will, if this was secondary, bone marrow, spleen, all of these would be involved. Okay, so this is what you need to remember. Understood this, everybody? So this is what is hemochromatosis. This is an eye ultrasound. What are we seeing here? We are seeing that there is a cystic lesion with central focal calcification. Very typical spotter. This you will see a lot. Very nice. This is cysticercus. So this is cysticercosis of the eye. So this is what is neuro. So basically there could be associated neurocysticercosis as well. So this is cysticercosis of the eye that you are seeing. Can you tell me a few differentials when you see that in the location of the globe, there is a cyst which is present? One very important DD here is the colobomatous cyst. All right. So very, very important. Colobomatous cyst. Coloboma means that there is a defect in the fusion of the embryological structure. So in that case, you will see that there is associated microphthalmia, and you see that there is associated cyst. So this is one of the very important DDs of a cysticercosis of eye. But here the central calcification gives it away, okay? Posterior lens dislocation will not have the central calcification, you know. So that's not this. So this is cysticercosis. DD will be colobomatous cyst, where you will have associated microphthalmia. All right. So this is basically the, can you see this? This is the retinal detachment which has happened, right? So this is retinal detachment, and then there is a subretinal cysticercus which is sitting here. So this is the globe. When you see this sort of a detachment, this is our retinal detachment, and there is a subretinal cysticercosis, right? So this is what is the orientation here. Fine. So this is about this. This is very typical. If I can give you a history, there was history of prior surgery in this patient. But if I would have given that, then it's a giveaway. So this is a spotter where no history will be given. Very nice. This is Gaussy pyboma. All right. So here maybe you have written the wrong spelling. If you have written the wrong spelling and you're poor at spellings like me, then you would lose your marks, because here Google form is going to check your spellings also. Okay, so how to report it if seen is, so you report it as a lesion with mottled recencies and high density within, likely a Gaussy pyboma. That's all. You have to report it as a Gaussy pyboma. All right, so this is because of a retained gauze piece. The hyperdense lines that you see here are the hyperdensities that are given in the gauze piece, right? So they are placed in the gauze piece so that we can recognize these on the x-rays. Same hospital है फिर भी you have to report it. Patient won't understand no Gaussy pyboma क्या होता है. That's why this is a phrase that you can use actually. You know, rather than writing retained gauze piece, it's better to report it as a Gaussy pyboma. Right, but you got to report it. ठीक है? So this is Gaussy pyboma. Don't have heartbreak because of spelling mistake, because I am not sure if this spelling is correct that I have written here or not. Okay, but yeah, this is Gaussy pyboma. In the actual exam, you will get your marks. What is this? This we just discussed yesterday, isn't it? ये तो हमने कल ही देखा है. What is this? Does anybody remember? Target sign, central hypo, peripheral hyper. What was that? Posterior mediastinal mass. Yeah, so this is a neurofibroma. So this is a neurofibroma, and when you see this entire temporal aspect involved, very good. This is a plexiform neurofibroma. So can I make a diagnosis of NF1 just on the basis of seeing this one plexiform neurofibroma? Can I make that diagnosis? Answer is yes. Even one plexiform neurofibroma is enough to call it NF1. So if you have written neurofibroma, if you have written plexiform neurofibroma, or you have written NF1, all three will get correct marks. The teaching point here is that the target sign is what you're going to see in neurofibromas, where they have a central hypointensity and a peripheral hyperintensity. Remember this because I'm going to teach you the same target sign in one more place, and that was also one of the spotters. What is this one? History of hypertension. What is this one? In the kidney, when you have multiple microaneurysms, there are two DDs that you have to think of. When there are multiple microaneurysms in the renal artery or its branches, two DDs. Very good. One is polyarteritis nodosa. Polyarteritis nodosa will have these small microaneurysms. And the second DD, if there is associated mass, then what will you think of? If I tell you that here there is a mass lesion, then what will you think of? Yes, very good. Then you will think of AML, angiomyolipoma. So two DDs of multiple microaneurysms in the kidney are PAN and AML. Remember, FMD, fibromuscular dysplasia, will not present with microaneurysms. FND will be a differential for renal artery stenosis. That the main renal artery will give you the string of bead appearance. There will be stenosis of the main renal artery. Here you see branches having these small microaneurysms. So FMD is not our differential here. So remember, 2DDs is a very important fact here. When you see microaneurysms, either PAN or AML, and that is why angiomyolipomas can rupture. In one of the quizzes later on, I'm going to give you a spotter which is going to be a ruptured AML. Very good. That is Wunderlich syndrome. So I'm leaking that question from here point only. You should all get it correct. Wunderlich syndrome is when you have retroperitoneal bleed on rupture of AML, and that is because of these microaneurysms. So anytime you have a microaneurysm which is 1.5 centimeter in an AML, this is an indication to embolize it. Two indications of embolization in AML is either aneurysms being more than 1.5 centimeter, where there is very high likelihood that they'll rupture, or the mass being more than 4 centimeters. So two numbers you should remember, that when to embolize a AML, if aneurysm is more than 1.5 or the mass is more than 4 centimeters, they have very high risk of Wunderlich syndrome. All right. What is this? Anybody got this one? Undescended testes. If you want more hints, this person has not seminoma. This person has GU anomalies, a lot of genitourinary abnormalities, PUV hai, MCUF. Very good. This is indeed prune belly syndrome. The name itself tells you prune belly. The abdominal muscles are deficient. So there's a congenital conditions where the abdominal muscles are deficient, and that is why look at the belly of this person. The bowel loops, everything is bulging out. So abdominal deficiency with undescended testes and associated GU anomalies is very typical for a diagnosis of prune belly. And this question comes as a spotter in a lot of exams. Okay, this is prune belly. Anybody got this? Hemopsis. What do you see in the CTP? I see that there is an aneurysm. Very good. So this is Rasmussen's aneurysm. Do you know what is Rasmussen's encephalitis? That will also be one of the spotters in the next quiz. Okay, so one more question I'm leaking. So you will read it up and you will come prepared. Fine. So this is Rasmussen's aneurysm, which is an aneurysm from pulmonary artery. So normally when you have hemopsis, the most common culprit is bronchial artery, right? Pulmonary artery, very rarely, when it can basically bleed, if there is a cavity, the pulmonary artery can erode into it and form this aneurysm. So this is what needs coiling. So this is an indication of coiling here, right? So this is Rasmussen's aneurysm, typically associated with TB cavities, active cavities, inflammatory cavities can have pulmonary artery getting eroded, resulting in PA aneurysm. So typically PA aneurysm is what is Rasmussen's aneurysm. Can you tell me two conditions where you see multiple pulmonary artery aneurysms? I'll be very impressed if you can name both of the syndromes. Pulmonary artery pseudoaneurysm will be considered. Okay, yeah, can consider. Yes, one is HHT, Osler-Weber-Rendu syndrome can have. Okay, name three. Three conditions. Thank you so much. Osler, Weber, Rendu, then Beshet. I love doing this. This Potter quiz and all I used to love when I was a GR and an SR. Now I get to do this again. I'm having a lot of fun. So we can keep doing this regularly. So one is Beshet. Third कोई बता देगा तो बहुत मजा आएगा. Anybody knows the third syndrome? क्या किसी ने ऊपर आंसर करा है? I don't know. Okay, I'll give you hint. No, I don't think किसी ने करा है. It starts with H. It starts with U. Yes, close. Very good. So this is U-Stovin syndrome, right? So there is a syndrome where you have multiple pulmonary artery aneurysm. So that's U-Stovin syndrome. Okay, so there are three conditions, three DDs that you have to remember for multiple pulmonary artery aneurysms. HHT is not really correct because here what you will have is multiple pulmonary AVMs. Aneurysm nahi hote, there are AVMs which are there, okay? But still, I mean, you can remember it with vascular anomalies. All right. So mainly Behcet's and Eutstovin are the two where you have aneurysms which are formed. Okay. This is, what is this one? Draining sinus से आंसर तो वैसे ही पता लग गया. This is Madura mycosis. So what happens in Madura mycosis is this target sign. Can you all see this? Just like NF1, this also gives you this ring in dot sign or a target sign. And what they say is that the central hypointensity is because of the fungal hyphae. And then you have the surrounding granulation tissue, which gives it the hyper intensity. Okay, so this is what is your Madura mycosis, giving you this ring in dot sign or this target appearance. Okay, ये तो बहुत easy था. So what you have is long bone fracture, and then 48 hours later you have this diffuse ground glass appearance of the lung, which is showing ARDS. So what does this make? This becomes a fat embolism syndrome. Tell me, is there any role of a CTPA in fat embolism? Is there any role of CTPA? No role of CTPA, right? Because these are microemboli which go into the small capillary level. So CTPA is of no role here. Just the X-ray will show you ARDS because your micro vessels or capillaries basically have these microemboli. Okay, significance of the days is that it typically occurs 48 hours later, right? 48 to 72 hours after the fracture. So it doesn't occur simultaneously, it happens later on. So आपको अगर 2 दिन पहले long bone fracture का history and then they are saying that patient has respiratory dyspnea or respiratory symptoms or ARDS, then this is what you should consider, which is fat embolism, right? There is no management, there is no role of thrombolytics here. You just have to ventilate the patient, give oxygen. That's it. No role of heparin, unlike pulmonary thromboembolism. That's the significance. What is this hernia? Anybody got this? What is the name of this lateral hernia that you have? This is the Spigelian hernia. Again, a very favorite, very good. Again, a very favorite spotter. So Spigelian hernia occurs. So you have your central rectus abdominis, right? So let's say this is the midline of the abdomen. This is the rectus abdominis. And then laterally we have the transversus abdominis. So this is what happens. This line inferiorly, let's say this is the pelvis. Okay, just go with my drawing. This is the pelvis. So this is the line which is known as the Spigelian's fascia. So यहाँ से herniation होता है. So this is usually infra-umbilical. So infra-umbilical, let's say here is the umbilical. So infra-umbilical between the rectus and transversus abdominis, this is where the herniation occurs. Okay, so whenever you see a suprapubic infra-umbilical lateral hernia, always think of this Spigelian hernia. Okay, yeah, this is the linea semilunaris. So this line here that I have drawn, that is what is referred to as the Spigillion's line or the linea semilunaris. Okay, that is where it happens. Anybody got this? Where is the pathology? The pathology is here on the left side. You're seeing air within the orbit. So this is what is orbital emphysema. It occurs because of complex fracture wherein you have the sinus wall getting fractured and you have air. So either the floor is fractured with a communication between maxillary sinus and the orbit, or the medial wall is fractured with communication between ethmoid and the orbit. Pneumo orbit, फाइन वी कैन गिव यू, ऐसा कोई टर्म होता नहीं है इन माय नॉलेज. दिस इज व्हाट वी रेफर टू एज ऑर्बिटल एम्फाइजीमा और द ब्लैक आईब्रो साइन. दैट्स करेक्ट. सो न्यूमो ऑर्बिट, okay, we can give it because you picked it up. Okay, so this is orbital emphysema. ठीक है. Pneumoconus, is that a term? Again, I'm not aware if that is a term. इसको technical term is orbital emphysema. Pneumoconus also fine, as long as you picked up the pneumo, we'll give it to you. What is this? This is my favorite spotter ever. So this is what people keep us like they kept asking us this spotter in AIMS. So you see that there is a membrane enclosing the bowel, right? So very common in our country because of tuberculosis. This is very nice. SEP, if you have written, we will give you the marks. So sclerosing encapsulating peritonitis. If you have written this, we will definitely give you all of the marks. Or if you have written cocoon, also known as cocoon, that's the other term, abdominal cocoon, we will also give you marks for cocoon also. So various risk factors for cocoon are Crohn's disease, tuberculosis, happens in patients who are undergoing peritoneal dialysis, um, happens in IgG4 related disease very rarely. And one drug that they used to love to ask us is Practolol. It's a beta blocker that nobody really uses. Practolol is a drug which can lead to this. It's not an internal hernia. Internal hernia जैसा लग रहा है because it's all collected on one side, but it's not a type of internal hernia. It's a type of peritonitis wherein you have a peritoneal thickening which is enclosing all of the bowel loops. तो internal hernia के marks नहीं मिलेंगे, but that's a good thought. But here you see this membrane, right? So this is what is SEP. So the abnormality is that all of the bowel loops are clustered and enclosed by this membrane. So it's a type of a peritonitis. All right, that happens. Cocoon, जैसे cocoon में होता है ना, that. Can it be ischemic bowel? No. No. No signs of ischemia, right? All the bubble wall thickness, enhancement, everything is normal here. ये तो कम ऑन दिस नोबडी शुड गेट रॉन्ग. ये तो हमारे थर्ड ईयर के बच्चे एमबीबीएस भी बता देंगे. व्हाट इज दिस? दिस इज रिकेट्स, राइट? सो दिस इज मेटाफिजियल कपिंग, स्प्लेइंग, फ्रेइंग. सो दिस इज नथिंग बट रिकेट्स, राइट? सो ये तो इजी, फाइन. So this was for everybody to answer so that nobody ends up with 0 marks. सबके 1 तो आ ही जाए. So this was rickets. So this is Dotarim. Dotarim is one of the contrast media that we use most commonly nowadays because it is safer. So this is a macrocyclic contrast. Macrocyclic agents are much safer. Why? Because they don't do what? This I've explained in the class of MRI contrast agent. They don't deposit in the brain. So they don't deposit in the brain, right? So their deposition is very rare, and yes, even their risk of NSF is much lesser. So that's why nowadays we're only preferring Dotarim for routine contrast study, unless you want a hepatocyte specific where we would use multihance or gadoteric acid, right? So this is an ionic macrocyclic. So only when you've written both, you will get the marks. Okay, so Dotarim is ionic macrocyclic, which is the best combination. Unlike iodinated contrast agent where we prefer non-ionic, in MRI it is ionic and macrocyclic which are the better combinations to have. Okay, ये किसने आंसर किया है? New onset hypertension with this subcapsular collection. Yes, very good. A lot of you seem to know it. Very nice. So this is a cliched spotter. So this is a page kidney where you have a subcapsular collection in the kidney, which could be a hematoma or an abscess that compresses on the kidney, activates the renin-angiotensin system pathway, and that can lead to hypertension. So the history, very typical history, new onset hypertension. Yes, there may be history of trauma or any sort of interventional procedure being done on the kidney, resulting in hematoma, resulting in hypertension. So this entity is what we call as page kidney. My favorite, if you have studied from me, you know that I love autoimmune pancreatitis, and it had to be there. So what you are seeing here is a sausage. Yes, sausage shaped pancreas. You are seeing that there is loss of lobulation of the pancreas and there is a fibrous rim surrounding it. Yeah, so this is autoimmune pancreatitis. If you have marked this, you will get full marks. It is seen in association with IgG4 related disease. It's the most common type of IgG4 related disease. Not edematous interstitial pancreatitis. That will not have this fibrous rim. That will be further swollen, right? It will not have loss of lobulation. That will be an edematous pancreas. This is not edema, it's very fibrosed pancreas that you have. Loss of lobulation. Normally, you will see the loss of you'll see these lobulations. Those are lost, and then you have this fibrous, non-enhancing rim. This is the typical appearance. All right. So this is what is autoimmune pancreatitis. And the last one was the easiest one, I feel. It was the very first spotter of the day we had put when conceptual radio started. This is a D-net, right? So you see this bubbly lesion, which is basically not showing any enhancement. So fluid-filled bubbly is the typical soap bubble, bubbly appearance that we call. If you have written D-net, you will get the marks. The full form is dysembryoplastic, the big name to write, neuroepithelial tumor. Okay, so this is a neuronal origin tumor, typically seen in young adults around 20 to 40 years of age, may present with focal seizure. So wherever it's located, it may present with a focal epilepsy or a focal seizure. So this is DNET, and that's it for the quiz. As far as the marks are concerned, we will announce the top 3 tomorrow on Instagram as well as Telegram, and you will be getting 3 months extension tomorrow itself. All right. So I hope this was good. What is your feedback? Did you like the cases? Did you like the experience? You have to say yes, unfortunately. But yeah, we'll be having this once in a month or so. All right. So thank you so much. Now I shall be meeting you next. I think next week. All right. So now we shall be meeting next week, but we have classes which are lined up. Tomorrow is your IR class by Akhil. Then we have a physics class by Nagesh. And yeah, that's what's lined up. Okay. How is it going? Every week would be too much, I think, of too much spotters. But yeah, twice in a month we can do. If you like this, we can do twice for sure. Echo to yaar, we'll have to bring somebody from cardio because I don't do echoes. I mean, we in our hospital it was cardiologist which used to do, but echo pe jana hai, to I think we'll have to bring somebody more specialized. Who has got the highest? Tell me your scores. Anybody getting more than 15 correct? We will check out your papers first. Anybody who thinks I've gotten more than 15 correct? So final years should find the quiz, I think, more useful than the first year. But first year, now you have a lot of time to learn, you know. So by the time you reach your final years, you will be pros in all spotter quizzes. You will do the best. So that's what's the plan. All right. So nobody more than 15, I guess. Nobody's coming up. So we'll see. I'll let you know how the scoring went by tonight. Okay. All right. Thank you. Thank you so much. And study well. Keep studying. There'll be videos which are uploaded daily. So keep doing it, because if you just let them pile, you won't be able to do. So रोज का एक एक कर लो. That is the accountability that you have to give. live and just take care of your academics. On the move, if you're on call, still keep seeing that one video every day. All right, so that way things will not pile up. Otherwise, before you know it, there'll be 40 videos which you have not seen, so we don't want to land up in such a situation. All right. Okay, thank you so much, and take care and bye.